I'd like to thank the organizers for inviting me. It's an honor to be here speaking to this group. I'm the director of the chiropractic program for VA, so I'm going to present the context of policy and planning and implementation of a new service in VA, and give some examples of how that has derived from policy and practice in the context most narrowly of chiropractic care, but trying to set the stage more broadly for VA as well. And I'd like to acknowledge grant support from VA HSR D and some foundation funding, and I have no commercial interests. So essentially, I try to cover some VA policy and practice initiatives and give an overview of a couple of services that are enrolled in the non-pharmacological management of pain in VA, and then more narrowly focus on some data we have from more than 14 years of experience of the chiropractic program in VA. And I'd ask you to try to look at this timeline first. Most of what we do in VA is either influenced or directly dictated by congressional authority. And prior to 2001, VA was delivering a number of non-pharmacological interventions for pain, including a number of the currently called CIH interventions. But in 2001, a specific law was passed that mandated VA to begin including chiropractic care. And in 2004, we issued a directive that actually started the provision of chiropractic care in-house at VA facilities, as well as purchased in the community. And then that evolved and grew slowly and quietly for a number of years. And then later on, in 2014, the Integrative Health Coordinating Center was stood up that Ben Kligler leads. And subsequently, the CARA legislation, which was a few years ago, that further mandated VA to expand additional non-pharmacological approaches, particularly in the complementary integrative realm, which led to the launch of the CAH directive. So this explains both the sort of similarities and differences between the way VA has unrolled chiropractic care and other things like acupuncture and massage, because they're actually policy driven by two different congressional mandates and have two different administrative lines in VA. And then just in 2018, the results of the HSR D Soda Conference. This conference was mentioned by a few speakers yesterday, and I'd like to start with that and actually work backwards. So the conference was led by Drs. Baer, Kearns, and Krebs, and is specifically focused on non-pharmacological approaches for management of chronic musculoskeletal pain in VA. And the proceedings were published in a special issue of the Journal of General Internal Medicine in May of this year. And one particular paper that came out of this was an effort, the paper was led by Dr. Kligler, specifically on clinical policy recommendations. And the group recommended that a number of non-pharmacological approaches are currently supported by enough evidence and enough policy implication to be delivered widely in VA and to be delivered early in the course of pain care, not to be reserved for some failed cases or some other secondary approaches. And you can see from looking at this list, there's some therapy, it was listed by therapies, not by discipline. And certainly, so this would require the expansion of certain traditional disciplines like psychology and PT, but potentially also the addition of new disciplines to deliver some of these other services. And one that has been more recently rolled out is acupuncture in VA. So for a number of years, VA has provided acupuncture by privileged providers who happen to have acupuncture training, so physicians and chiropractors, and only recently has added licensed acupuncturists to the mix. We've also partnered with the Department of Defense in battlefield acupuncture training, which is a specific protocol for ear acupuncture. And the use of acupuncture in VA has subsequently been increasing. Numbers that I've received from Ben's office show the number of unique veterans receiving acupuncture increasing greatly from 2017 to 18, and the number of visits they're receiving. We have some obstacles in data collection with VA administrative data that have been modified and working on to get more robust data capture on the use of some of these therapies. So we see this is already happening. Chiropractic care, as I mentioned, sort of predated this. So in 2005, VA met the requirement of the legislation, which was at that time to have 21 on-site chiropractic clinics. And that was the legislative mandate that remained until only more recently. So any growth we've seen from '05 through 2018 has been natural organic growth of the program as it has gradually been uptake. We've seen uptake through different facilities. So we currently have about 170 chiropractors at 99 VA facilities providing care. In 2014, with some colleagues in VA HSR D, we published a qualitative assessment of the initial implementation of this program, where we visited 7 sites and interviewed over 100 stakeholders on how this was unrolled. And we identified some barriers and some facilitators that may very well be applicable to VA unrolling other services in this regard as well. And the 3 main barriers that came on the 3 themes. The first was individual physician negative perceptions, and particularly when the physicians were decision makers at chief of staff or chief of service line levels. And particularly these were personal experiences or knowledge that individuals had nothing to do with knowledge of data, but just particular perception. The fact that this was originally a non-funded mandate for VA, so Congress told VA you have to do this, but there were no specific appropriations. And as was mentioned the other day, there are competing resource priorities even for something that's a relatively low cost, like adding a chiropractor or 2. And early on, facilities told us there was really no good guidance on how to do this. Back at that time, we didn't have very good models for implementing chiropractic care in a large system, and there was not a real lead from central office on how to do this. And then we also identified the converse, the strongest facilitator was positive perceptions by individual physicians and decision makers. And proportionally, there were more of those than negative perceptions. And it usually, again, came down to firsthand experience. So a physiatrist who said, I've worked with a chiropractor privately, and I know it's worked for my patients, so I value that. We subsequently, over the years, have been able to develop some funding initiatives that have supported the expansion of chiropractic care. And right now, working on one where certainly the uptake is greatly enhanced by that. And then later on, facilities told us that the central office guidance that came on after the initial several years helped to now give facilities a blueprint on how to develop this and implement it as they go forward. Interestingly, there's 2 themes that were not really reflected. One was the patient preference, and the other was the degree of evidentiary support, and both of which were existing over this time, but surprisingly, or maybe not, most stakeholders were not influenced to accept this more based on either patient preference or based on the preponderance of evidence. It was more the one-to-one experiences and the shared experiences that really tend to drive the ship on that. We also subsequently published some data on usage on the first 11 years of the program, and I've supplemented that with some administrative data for you here now. So the first point is chiropractic clinics in VA are enrolled in one of 3 main models, either in physical medicine and rehab, in pain medicine, or in primary care. So they're all in some type of a team-based approach. We intentionally allow facilities to vary the way this is implemented. We see that it has worked in all 3 models, and the team dynamic is different in all 3 models, and even within models, and even from one VA facility to another. But it has been able to be successful unrolling these types of teams across these different service lines. The use of chiropractic care has grown on average about 18% per year since fiscal year '05. Now, these absolute numbers are still very small when compared to VA's overall population, but we have seen this steady increase and uptake of services. And we've seen an equal increase in our use of purchase care in the community when we look at VA's mechanisms for buying care externally. When patients receive chiropractic care in VA, it's most commonly for low back or neck conditions, which is what we would expect, typically what chiropractors manage in the private sector. So And most of those conditions are certainly in the subacute to chronic pain range. So the vast majority of what VA chiropractors do is manage chronic musculoskeletal pain, part and parcel of the importance of this event. We see patients across a wide age and disability spectrum, but the population is skewed towards the more complex multimorbidity patients. Although we notice that VA chiropractic users tend to be a little bit younger and more likely to be female than the average VA patient that use outpatient care services. And that matches the current cohort of Iraq and Afghanistan veterans who are more likely to be younger, more likely to be female, and more likely to have chronic musculoskeletal pain and mental health illness as their two main complaints. So this is a priority population for VA, and this is one way where we've been successful in sort of matching the therapies, non-pharm therapies for this group with this growing priority population. And lastly, I'd just like to summarize one outcome we've looked at with colleagues at the Prime Center and Yale. We've looked at opioid use among the veterans of the recent conflicts in Iraq and Afghanistan, or as we call OEF, OIF, and OND in VA. And I just have one slide to show the summary of that. So over a 10-year period, we identified over 14,000 chiropractic users among this population in the VA system, and about 4,300 of them had also received an opioid prescription. So that rate of about 30% is about equal to the ambient rate of opioid use in that population for chronic pain conditions. And when we looked at the timing of the prescription fill, in any of the 3 30-day windows before an index chiropractic visit, the percent of the population to fill a script was much higher than any of the 3 30-day windows afterwards. So this was just an observational study where we did not look at more detailed factors of causation, but it gives us some solid preliminary evidence to look at this more closely, particularly when we have some existing evidence from outside the VA that shows some of these same results, and we're trying to dive into the data more closely right now. So I'll just summarize. That's my last thought. I'll just summarize by saying we have been able to implement chiropractic care in VA to support the appropriate use of evidence-based non-pharmacological therapies. The things that VA chiropractors do are congruent with current clinical practice guidelines in terms of the way we've unrolled services. And in a team-based model, the services have been received and taken up by facilities and expanded laterally across the system. And I think it serves as a model for VA to expand other type of non-pharm approaches. And I think by some stroke I was given 15 minutes instead of 10, but I'll stop early. Thank you.